This is where you're going to find the majority of the patients in your practice. And you're going to see the pure bulimic who has the pathognomonic lesion. You're going to see different things, but most people are going to fall. They got a little bit of this, a little bit of that. Something's overriding, but usually it's a little here and there. And again, good literature where you see multiple lesions or additive effects in various patients. This is from Grippo's article. This was in JADA 4 or 5 years ago. Just sort of laid it all out. What everything can happen to you can happen to your teeth. Endogenous, exogenous causes. It's too small to read, but by example. This all fits together. So that would be a patient who has attrition. That wear pattern is fall, right? But you see, there's these horizontal striations in the root area. Someone's scrubbing them pretty strongly. And there's like a washing out effect here and there. So it's probably a combination of someone who's doing toothbrush abrasion, they're grinding their teeth, and there's probably some erosion in there too. That would be a pretty typical patient that I would see. Not just one thing. And the one that worries me the most is, of course, the grinding, because that's going to be my restoration. And the other things, hopefully, we can educate through, teach them how to toothbrush. Again, from Grippo, you got your different forms, and they come together. This is where I'm going to find most of my patients. But you'll find this, you'll find the rupture, of course you do. Of course you do. And you'll see what Grippo thinks is the outfraction. The other guys say maybe not. But it all sort of tends to overlap. And another example. So you've got some wear, there's some sharp little edges there. They're chipped away. You've got the cupping effect, so it's worn through. So if you've got the cupping, so we know they've got some kind of a occlusal structure loss there from bruxism or some form of grinding, some degree of grinding. But you've got this softened appearance where it's just been abraded, rubbed away. So that would be a pretty typical mixed etiology patient. And one last time to go back to this reference, and if you have your old JADAs and you can go look for it, that's great. If you don't, you can call me and I'll look for mine. And I'm sorry I don't have it with me, the reference, because I got a stack of JADAs in my right now. But it's a pretty nice article to have, so if you need it, reference, by all means, get in touch with me, I'll find it for you. But it's just, when you look at all the different categories, habits, dental hygiene, not just from the patient, the dental hygienist too, right? You've got patients that fall, patients that have been with you for 40 years, they've been scaled root clean for a while, and eventually, you lose a little bit of tooth structure. So there's different ways that you lose it. All right, so lastly in this area would be the patients that they seem to be every one of my patients. They all say, well, I have soft enamel, doc. Everyone in my family has soft enamel, right? Yeah. Well, some people did, right? Some people do. So let's benefit of the doubt. But there are various degrees of enamel problems. And you think of amelogenesis imperfecta, you think of dramatic cases. Now, again, spectrum, right? Most of these diseases are in spectrum or conditions. So you've got people with thin enamel, people with soft enamel, people with hypocalcified. There are various degrees, and these patients are, of course, much more at risk of the breakdown. And a few other things. Different types of defects. These guys are talking about getting Turner, Vesuvian. This is the reference for the categories of loss of structure. So it's good literature. Fortunately, it's nicely documented stuff. Even though if they don't all agree, there's really a lot of good. And they also